Hey everyone, welcome back. Shaun, Brewster, Bodine and Ledden here today. Today we're talking about posture and the question, does it matter? Now, you just recently wrote an article on this. Talk everybody through the concept of this discussion today.
Yeah, well, I think myself and everyone else out there has probably learnt posture and postural screening, postural assessments, and this is something that's been ingrained in people from their early training. And often, the stronger that someone believes in something, the more that influences their patients, and then patients believe that they have something wrong with them, that they've got structural malalignment or indiscrepancies or postural dysfunction because certain bony landmarks don't line up. And when we dive into the research and the current evidence surrounding postural assessment, it's just not supported. And I know that this will go against a lot of people's beliefs, but that's why we have some really good, strong evidence to back up these claims. That I'm now moving towards the opinion that posture is just not so relevant, especially not as relevant as what we once thought it was.
Yeah, absolutely. And this is a topic that I know that when you wrote your article and put it out there, there's been quite a few comments of people saying, fantastic, finally, someone's actually summarized this in a way that my brain can understand. I've been thinking these concepts for a long time, but they've flown in the face or gone against what I was taught at school. And you and I both have taught in undergraduate programs before, and we are forced to teach the curriculum. And the curriculum almost always includes some training around postural assessment and then taking that data and using that to inform a treatment plan. And while you can certainly do that, and you can apply that cognitive bias to that, understanding of how the body works, and you can treat somebody and then they can feel a bit better afterwards. You could probably do other things, treat the opposite of that reasoning, and they might still feel better. So here's the challenge that we have: is how much does posture actually play into somebody's pain presentation? And I was really happy to read in your article, you're talking about the fact that we can't really link pain and postural discrepancies together. The evidence is not strong enough. Now, there'll be people listening to this that will say, but hang on a second, the postural assessment forms the majority of what I do in my clinical assessment. It's what I hang my hat on with every treatment. I say, here's the postural discrepancies. I assess for that. I get the information, then I treat, and the person moves and feels better. How can that be wrong if what I'm doing is achieving positive results? How would you answer that?
Yeah, well, I mean, you and I both look differently on the outside. Why should we be assumed that we should look the same on the inside or have the same bony structure and bony landmarks? And you could look at someone's posture and go, well, I mean, it would make sense to say, well, this muscle is short. So if your shoulder is rolled in, that, yeah, you might have a short pec major, and the opposing muscles might be longer and weaker. I mean, it's simple, but that's it. It's very one-dimensional view. I mean, yeah, you could rub an area, but at the end of the day, we're not deforming any tissue anyway. So, maybe they feel better, but it's not due to the mechanisms of actually changing their posture or correcting their alignment or putting them back in place. That's just not supported either. Yeah, so because it's easy to look at someone and you go, oh, well, they must have tightness there. They need some strength exercise there, or they need corrective exercise to correct their dysfunction. And again, just not supported. It's sort of a very simple one-dimensional way of looking at things.
Absolutely. And we've all been through that class where the teacher was teaching us postural assessment, and you and I have been in the class being that teacher teaching postural assessment. And I don't know about you, but I've had a group of, say, 20 students, and I say, right, let's do a lateral view postural assessment. And we want to see external auditory meatus lining up with acromion, lining up with greater trochanter, lining up with lateral malleolus. And then we stand somebody up there as an example, and it's a zigzag. It doesn't line up. And across that 20 or so students, there'll be two, maybe one, really have that perfect alignment, the textbook alignment that we are suggesting that every one of our patients should have. So again, the stats don't line up. If all of our students in a classroom aren't aligned and they don't have pain, well, then how important is this postural assessment?
Yeah, and look at where it's coming from. You could look from a very biomechanical viewpoint at someone's posture, but there's stronger links between the psychological influence of posture. People have mood-related disorders, psychological conditions where they may move into different postures as a result of that. So how could we then possibly link, well, posture is the cause of your pain when we know that there's stronger links with depression, anxiety, mood-related disorders, and pain sensitivity. So, it just doesn't make sense.
It doesn't.
Because you could have someone and then you stand them upright, you tell them to adjust all of their body positions, and then let's get you into this perfect alignment, but the pain doesn't go away.
Yeah.
And again, that still doesn't make sense because it's a one-dimensional approach. We're not addressing the multiple factors that are involved.
That's right. What would you then say, and we do talk about this in our joint mobilization course and other places, where somebody presents with a local area where the bony anatomy is not in the ideal position for arthrokinematics or biomechanics. So, for example, somebody might have an anteriorly tilted scapula or a lowered lateral margin of their acromion. And so when they go to do something like abduction, we get in a more immediate impingement type presentation going on in the shoulder. Now, that's not full body anatomy. That's not gross postural assessment like we're talking about here. But what about those small torsions, asymmetries, undesirable positions of certain joints that then can be linked to poor biomechanics, which can be then linked to pain presentations?
Yeah, but that's the thing. There's quite a poor link there. When you look at a type 2, type 3 acromion, people with type 2, type 3 acromions also have no pain. So we can't necessarily say that people that have some form of bony abnormality or impingement will have pain because, everyone's going to have some form of impingement through the shoulder. And understanding the amount of humeral version, the shape of their glenoid, the position of their acromion. At the end of the day, they've probably got pain because they're deconditioned to a certain movement, or it comes back to the amount of load and the capacity of their tissues, as well as various other factors that are involved in pain sensitivity and a pain experience. So we can't just pick out the position or particularly in chronic pain and say that that's the cause of your pain. And if we correct that, then it's going to get better. Because, again, we've even seen that in shaving away, like a subacromial decompression surgery has no better outcomes than exercise and conservative management. So you can still get better without having to remove a piece of bone. It's not just about a posture or a positional change.
And the body's got an incredible capacity to adapt to less than ideal positioning to find a way around its dysfunction or its problem. So, for example, the one I was using before, if we've got that anteriorly tilted scapula causing a lowering position of that bone, and then someone's trying to move into flexion or abduction to reach overhead, well, then we don't move our body in single planes and at one joint at a time. If I try to reach over my head, I'm going to produce some abduction, some thoracic extension, probably a little bit of lateral flexion of my trunk to reach overhead. But we'll put that person in a seated position when we assess them and ask them to raise their arm without moving anything. And no wonder they're getting impingement sensations or problems or pain. And so, yes, we might be able to tape their scapula into a better position, maybe work on strengthening some muscles to produce a more ideal anatomical perfect. We haven't accounted for the fact that they found ways around that anyway. Their tissues developed the capacity to withstand that load. Their spine moved in a way that allowed them to get the range of motion they needed. We don't have to be robots. We don't have to move in 2 dimensions. We've got 3-dimensional capacity, and our tissues have the ability to adapt to different types of load and situations. So I think it's this postural paradigm is very much looking at things very black and white, very 2-dimensional. The body just doesn't work like that.
Yeah, exactly. And you look at a classic example is low back pain, right? In 90% of the cases, there's no specific pathoanatomical cause of low back pain. And then someone comes in with chronic low back pain and someone goes, oh, you've got an anterior pelvic tilt. That must be why. All right, and that doesn't make any sense either. Let me bring up some research here. A paper by Harrington, they assessed the normal pelvic tilt, right? And the results of the study showed that 85% of males and 75% of females have an anteriorly rotated pelvis in a normal asymptomatic population. So it shows that an anterior pelvic tilt is completely normal. It's very common in asymptomatic people. It's in fact far more common than people who have an anatomical neutral pelvic position. All right, and that's normal to have that. So we can't label that as a problem. Furthermore, there's another great paper by Rousley and colleagues. They had 160 normal subjects. And what they did was they assessed the alignment of the spine, the sacrum, and the pelvis. And they found that the angle of the superior end plate of S1 with respect to the horizontal axis varied between 20 and 65 degrees. Right.
That's huge.
So you've got S1, right? Horizontal axis here. So S1 could be angled between 20 and 65 degrees. So you can imagine how that might influence the position of the pelvis, the lumbar lordosis, and this is all in asymptomatic people as well. So it's completely normal. And they also found that the angle of global lumbar lordosis varied between 41 and 82 degrees. Huge amount of variation, again, in normal subjects. And also, the vertebral bodies in a lordotic orientation varied between 1 to 8. Typically we think, well, the lumbar spine, L1 through to 5, that's the lordotic orientation. And then we have, your universal joint at T12, where we're going to have that change into a thoracic orientation. So understanding these morphological variations that are completely normal goes to show that this generalization of a kyphotic posture between T1 and T12 and a lordotic posture between L1 and L5 is overly simplistic.
100%. Yeah. But we see, and again, there'll be people watching this going, but I've done this with my patients where I take a photo of their posture, day one, and then I treat them each week for 8 weeks, whatever the time period might be. And then we take a photo at the end and they're a different shape. Like I've reduced the kyphosis. There's less anterior pelvic tilt. We're getting less of a forward head positioning. Now, I'm going to give you my opinion on that, but I'm going to let you go first. What's your thoughts on that?
Classic. I see this all the time and it sort of grinds my gears a little bit, like especially the ones pre and post session, because, you could take a photo of someone when they come in and then you talk to them, you educate them about, all of your findings and why they're short and tight and the positions that they need to stand in. They get up. All right, let's assess your posture again. And just by saying that word, if I said to you, sit in a good posture, you'd go, oh, what I perceive to be a good posture might be an upright position. All right. So they might, as far as their beliefs and their thoughts and expectations and trying to please you as well, there's all of these other factors that are involved. But it's one of those things that you might see some changes in someone's posture, but what's the reason behind that? You didn't mechanically deform their tissues again. It's just potentially that their perception of being in a different position.
That's right. Yeah, 100%. And so somebody they can change from the start of a treatment to the end based on how they feel. Like you're saying, the connection between psychology of somebody, their emotional state, and their physical body dramatically changes from minute to minute. I know if I'm, down about something, you could probably see it in posture. And so there's those links for sure. And of course, you're probably going to feel better in your body at the end of a treatment because you've had all this nice sensory input. So you feel happier. There's endorphin release. Your body feels a little lighter. So of course, there's the potential for you to stand up. There's also the desire to please your therapist, right?
Yeah.
And so we want to be, like you said, someone says, let's assess your posture. So you want to stand up nice and tall and go, look how good I am now. That can be tracked from the start of the treatment to the end. It can also be tracked from one treatment to weeks and months later. But in those weeks and months of treatment, when the patient's been coming to see the therapist and the patient walks away, each time feeling good in their body, feeling a little bit more likely to say move better and exercise more and be a little bit more active, through those activities, we develop greater tissue capacity. With greater tissue capacity, we tend to move more freely and more ably, more mobile. And so it's no real surprise that the person might be holding themselves a little bit differently. Did we form tissues? Did we change the position of a scapula, a pelvis, a spine, a knee, whatever? Probably not. We gave the body an opportunity to find a more comfortable position for the appropriate muscles to contract at an appropriate length, and for the tight connective tissue that might have been restricting movement to sort of soften, and then the person can move more freely into ranges of motion that they didn't have before. We're not pulling sarcomeres apart and permanently stretching them with a massage. We're not dry needling something and perforating scar tissue so that it can be released like we've done it with a scalpel. There's no magic pill. And so I think anyone that's doing pre and post photos, be really cautious about what that says to the community, but also what it says to the patient. Look, you had a problem before, now you don't. What if that patient sees their photo and still has pain? Then it reinforces into them that maybe their pain is actually more serious and not something that can be resolved with the help of you, the therapist, or with anybody else. Maybe they feel like their situation is degenerative, it's chronic, it's it can't be relieved. And so the pre and post photos are probably good for weight loss stories. And maybe that's where we put a full stop at the end of that sentence, because there's not really much more use for them.
Yeah, I agree. That was really well put. Yeah, and labeling and pointing out indiscrepancies and things like that, it's nocivic. So it can have a very negative influence on our outcomes long term and patients' perception, because they often don't know that until you point it out to them. They go, "Oh, I noticed your shoulder was sitting up like this. Your head's off to the side. You've got a scoliosis." Forever, for the rest of their life, they will hold on to that. I've got pain because of my scoliosis, and that can't be fixed. Or I've got an anterior pelvic tilt. So what? People with those same structural abnormalities or differences can have completely no pain. But you'll have patients come into your clinic all the time, and they'll know that my shoulder's sitting up on this side, and that's the cause of my neck pain. Well, is it really? In fact, there's studies showing again on differences in lumbar erector spinae bulk or cross-sectional area and the multifidus muscles that is completely normal to be at least 10% different side to side. So when you think about that, well, that's completely normal. There's studies going to show that people who have in fact, I'll read this one out because this is an interesting one. When people often think that neck posture or this forward head neck posture is related or linked with increased chances of pain. So there's a study by Richard and colleagues that they aim to determine whether sagittal neck sitting posture in late adolescence was a risk factor for persistent neck pain in young adults. And they found that females in late adolescence who sat in a slumped posture or thoracic slump position with a forward head posture, rather than sitting in an upright posture, had a lower risk of persistent neck pain as a young adult. And that'll often go against what a lot of people would perceive. And you think classic low back pain again, and if people have low back pain, they think, "Oh, I have to sit up in this upright posture," and that's being in that stiff upright posture can instill feelings of increased fear and instability, or if structural dysfunction if they move into different postures. Let's just get people to sit and stand and move in comfortable postures, move around, sit in different positions. I mean, if you do anything for a long period of time and you don't have the capacity to hold that, you will get tired, you'll get fatigued, you'll probably get sore, and you'll probably feel pain. But if you give yourself a rest, get up, move around, walk around, do some exercise, all of that sort of stuff, then there's no one perfect posture. And physios and health professionals and even patients don't agree on what an optimal posture is. So if there's no such thing as an optimal posture because no one can agree on it, there's no research to link a certain posture to poorer health outcomes. How are we educating people on how to sit and stand if there's no gold standard? And what are we trying to correct when we've got no baseline to compare it against, So it doesn't
it's
make
frustrating.
sense.
It's crazy, and we see this all the time. Where I went and saw my therapist, my whatever practitioner, and they said my neck pain is as a result of that forward head posture, or my shoulder pain is as a result of that, scapular positioning, whatever it might be. How does that practitioner know that they haven't had that problem for 30 years, or that problem, I should say, that postural positioning for 30 years? Pain started 2 days ago. How can we link something that's been there for decades, months, days, whatever it might be, with something that's more recent? It just doesn't make sense.
Yeah.
We see this with, classic example, we were talking a little while ago about FAI and the bony abnormalities that people present with that. But their pain started 2 or 3 months ago, and they've had that same bony deformity for most of their life. We can't always connect structure with the functional negative outcomes that people are perceiving and experiencing. Just, you can't draw that line between the two.
Yeah, and also the problem with that is some some practitioners may look at someone's posture and go, well, you might not have posture pain now, but you will. And then that induces a lot of fear and, oh no, I'm going to have to keep going back for these sessions so that someone else can put me back into alignment, or someone else can fix me. And that creates reliance on that therapist, and potentially more avoidance of, oh, I don't want this to get any worse. It's negative. It's really negative. And I've even seen printouts, multiple page printouts of x-rays of showing every sort of slight change in symmetry, and it's sort of like the influence of that. People go, oh my god, I'm broken. I didn't realize how broken I am. This is really bad.
Yeah, and this is akin to a witch doctor pointing the bone. Point the bone, you're sick, and then just wait. That person will get sick. They'll talk themselves into it because the belief is so strong. And so you're right. And we could probably have another discussion at another day about the damaging impacts of imaging, medical imaging.
Mm-hmm.
That's something we need to chat about at some stage as well, because it's I've got a relative of mine who was looking forward to getting some imaging done to confirm for themselves that this was the problem. And once they got the imaging done and someone said, look, here's the thing, and I went, oh, thank God, that's why I've got my pain, because it didn't make any sense. But how do we know that thing wasn't there 20 years ago when your back was absolutely fine? It's just these joining the dots just doesn't make sense for us. So it's a precarious line that we tread with this one for sure.
Yeah, that's the thing. Like, you look at imaging and someone might go, well, that's quite validating. That's the reason for it. But the opposite also happens when, oh, they didn't find anything on my scan. So even more confusion and all of this sort of stuff. And we just know that pain is more complex than that. Pain is far more than structure, alignment, biomechanics, all of this sort of stuff. There's far more to it. But yeah, by then pointing out certain things to a patient, that goes, some of them may take that on board and go, oh, well, that's it. That's my reason for it. Some people also take ownership of that's who I am. I'm the person with the pelvic.
That's right. It becomes their center, doesn't it? It becomes the center of their universe. Yeah.
Yeah. And I just want to bring that up again on pelvic tilt, because that's something that's so often overemphasized with hip, SIJ, low back pain, when someone will go, well, you've got ASIS, PSIS discrepancy on one side, it's different on the other side, which means that you may have a pelvic torsion, you've got an upslip or an inflare, and all of this is unreliable as well. But there's a study by Priest in 2008, which is a great study, as a cadaveric study, looking at the differences between normal morphology of ASIS to PSIS. Excuse me. And the ASIS to PSIS angled different in 20, I think it was 26 subjects or something like that. And the height difference was between 0 to 23 degrees in normal pelvises. So you could look at someone and think, wow, that's a huge anterior pelvic tilt. But that's a completely normal pelvic position. It's just that their ASIS and PSIS are in a slightly different position.
Because the bony morphology.
Yeah, and you've only got to think about how we've evolved, our bones aren't the same as they used to be, and they're not the same as they look in a textbook. Everyone's body shape, size is different. So we can't expect that bony landmarks will be the same for you as they would be for me, or a female, or someone that's 20 or 30 years older than us, or younger. So we've sort of got to take that with a grain of salt and just say, look, delete this word neutral posture and neutral pelvis, and just replace it with comfortable. Find a comfortable position.
Yep. Well, I'm going to throw a cat amongst the pigeons here and then give you my perspective. I'd love to get yours on it as well, which is all the power lifters, weightlifters out there are going to look at this and say, well, hang on a second. If I don't use good posture, good form when I'm lifting, I hurt myself, or I damage myself, or I have pain. And so I would say there's some truth to that, because biomechanically, the body's going to have certain advantages in certain positions. If you're stacking a couple 100 kilos on a bar and trying to lift that with your body, there'll be certain points where you can position your center of mass, your center of gravity, so that you have biomechanical advantage to create better leverage. That makes sense. But what we're not talking about there is we're not talking about positions that you would hold yourself in all day while you're at work, or positions while you're playing, sitting on the floor playing with your kids or watching television. That's vastly different to someone loading themselves up with huge amounts of weight and trying to lift it off the ground against gravity. And so I think we need to be really careful about differentiating these two things. One, ideal body positioning, and they won't be the same for every single person, but ideal body positioning for an individual to create leverage, to move weight, to move mass, versus ideal body positioning, which doesn't exist, for the general population doing general daily activities so that they don't have pain. And so I'd love to get your thoughts on those two things.
Yeah, okay, good one. So when we look at, firstly, static postural assessment and then pointing out discrepancies, that's one thing. Then when you've got a dynamic movement such as a heavy squat, right? There's no literature that links a pelvic tilt position or a lumbar flexion to increase incidence of pain. So, I mean, there's some people that will have different techniques, one versus another. There's studies to show that even in elite powerlifters, the level of pelvic tilt is different, and the level of lumbar lordosis or lumbar flexion is different. So there's no one right way to do it, and there's nothing to say that because you have slight amount of flexion through the lumbar spine that you will have pain. When we look at those types of populations, that's when we're looking at other factors such as their volume, the intensity, the training frequency, their rest, their sleep, their nutrition, all of this other stuff that comes into it, because anyone in any posture could have an injury if their training variables aren't right. Yeah. So there's a lot more to it. Yeah, there's certain positions that might have more efficiency, but in saying that, right, if you go to they've shown that it is more efficient to lift something off the ground with lumbar flexion than in a sort of a lordotic straight spine position. So there's increased neuromuscular activation in a lumbar flexion position. So interesting when you look at it like that. And that is a big argument. This, the flex spine versus a straight spine position, or upright postures and all of that sort of stuff. But it's a really interesting topic when we look at both sides of the evidence and different opinions.
Yeah, that's right. And I think from a clinician's perspective, the thing to focus on here is, okay, you might have an elite power lifter, you might have a cyclist, you might have a golfer, three very different things. And then you come in, you do a postural assessment on them, and you see that they have this, it's like increased kyphosis through their thoracic spine, and it looks like maybe one of their ASIs is a little lower or higher than the other. That's the situation. We have to see that and go, it's your reality, no problems. Is there any link between that and your current pain or your current issue? Who knows? We probably don't think so at this point in time. But let's see how you function. Let's see how you move. let's figure out what strategies you have to find your way through flexion, find your way through extension. How do you reach overhead? When you rotate that golf club, where do you turn from? Which joints are more mobile than others? Where are you compensating? Those are the things that we as clinicians got to look for. Once we can understand a patient's strategy to move, we can support that strategy as opposed to trying to find something structural that's asymmetrical and correct it, because we might be correcting a bony morphological change, which is impossible. Unless you're a surgeon and going to go in and shave off an ASIS, you're not going to change it. But if we try, and if we were successful, let's imagine we're successful for a moment, we might be correcting it too far in the other direction because we're unaware of those bony changes that have taken place or that they've had since birth. And so we focus on the function, ignore the structure to a degree, take it in as part of the data, but focus on the function and the person's strategies around that.
This is an interesting one. Very early in my career, I just graduated. I was doing some work with the AIS athletes, and I was, I'd learn all about posture and structure and alignment and all of this sort of stuff. But then you'd see a hammer thrower come in, or a shot putter, or a javelin thrower, and they've got this significant variation in symmetry because they need that for their sport.
Yeah.
They're a right arm shot putter. They're going to have more muscle bulk. They're going to have changes in symmetry on that side. That's normal. That's completely normal for them. We don't need to change that. And if they walked into your clinic and you pointed all of this stuff out to them and said, well, we've got to lengthen these muscles, we've got to strengthen these other muscles, it just wouldn't make sense.
No, that's right, especially in those unilateral type sports. And so we all have a dominant side. And I said, this is another thing that comes up. It's like, you've got this problem because you're right-handed, and that's why, you're right side dominant. Therefore, this is what's happening with your body. Well, everybody is one side dominant. If that was the case, then everybody should be having these issues. And so we've got to be really careful about looking at those, those structural differences, and then how the person's trying to join those dots that just don't exist. But this is a really important topic, I think, and one that you and I find ourselves talking about more and more in our discussions, both in the classroom and just in private as well. It's a frustrating situation because so many people are still being taught in this structural model of understanding when it comes to posture. And that's kind of okay because it still helps people understand the body, the human body, and understand its structure and its function. But I think we need to move away from that as the starting point in somebody's assessment. It's a snapshot in time as well, right? It's like when you look at the way they hold their body, it's like an X-ray. It's that moment on that day in that situation for that person. We could do the same postural assessment on that same person tomorrow. It could be vastly different.
Yeah, that's it. Everyone's different. We've got to remember that. And why do we need to fit them into this perfect anatomical position that we see in textbooks? No one moves like that. No one looks like that. It just doesn't. It doesn't matter. Again, no research linking that to better outcomes. In fact, sometimes it actually can make people worse because they're overprotective, they're overly guarding, it's just obviously influences their beliefs, and beliefs influence their behaviors, and so on and so forth. So. Yeah.
It's the merry-go-round that people get stuck on when they're given the wrong information. So I'd say you probably agree that the most important thing we can do is help the person understand their situation better and give them solution strategies and a little bit of support in moving to a better situation. We don't need to fix them. If their body's fine, we don't need to fix them.
Yeah, 100%.
Yeah, great. Let's call it quits there, Bo. Thank you so very much for that topic. I'm sure that's going to generate quite a bit of discussion and hopefully a bit of introspection with everyone that's listened or watched this. Thanks everyone for tuning in. Catch you next week.
Thank you.